Okay, it's 12:15. So congratulations for surviving the corridor outside. That's pretty hardcore. I'm glad we're in this air-conditioned room. I'd like to welcome a really fantastic panel. I'm Andrew Sharp. I'm a consultant cardiologist from Cardiff in the United Kingdom. I work in a STEMI centre that does about 550 PCIs, primary PCIs a year. So we do a lot of STEMI. It's great to be joined by Professor Irene Lang from Austria, who's an expert in most things, but has very much an interest in aspiration and the science behind what comes out of the coronaries. We have Jay Matthews, who is the PI of the Cheetah study, which is some of the data we're going to show you later on the use of the penumbra coronary aspiration technology, the CAT-RX, which has just become available recently in Europe. And we also have Juan Iglesias from Switzerland, who's getting a lot of experience in Switzerland, and he's going to give us a European flavour in a couple of cases where he's used the device. So this is a new area that has a little tinge of controversy going back 20 years, and we'll hopefully tease a bit of that out, and we'll see where this is going to be. So I'm just going to go to my slides now, just one moment. So, session objectives. My conflicts include penumbra. Okay, so what is the problem? Well, the problem is that when you have that and you balloon it, you very frequently end up with that. And there isn't an interventional cardiologist on the planet who hasn't experienced this, where they balloon thrombus and it embolizes downstream and then you have no reflow and you're in trouble. And we're going to tease a little bit more of the data about what happens when you do get no reflow, because it's not good. What is the pathogenesis? Well, it's not just embolization, although that is a major part of it. There's ischemic injury, reperfusion injury. We have some patients who seem to be susceptible to it. And then there's microvascular obstruction that's chronic versus acute. So there's a lot of it going on, but embolization seems to drive a lot of this phenomenon. And no interventional cardiologist needs to be told about this. So we've had large-scale aspiration trials before, and occasionally I make the mistake of getting into debates on Twitter about this. Because if you go on Twitter and say, I think there still might be a role for thrombus embolization, you will have about 5 people piling in on you saying, we've proven that doesn't work. Well, what we've proven is that if you take a very narrow, simple device and try and routinely aspirate all STEMIs, then you end up with a neutral result, with a signal of higher stroke. However, what's not in doubt is that if you have no reflow, a phenomenon driven by embolization, you have worse outcomes. And if you have no reflow in the LAD, you have terrible outcomes. The outcomes within TASTE and TOTAL for patients who had no reflow from a proximal LAD, in fact, was very poor. So we have a clinical problem. So I like to spend my time not trying to solve problems that don't exist. I don't like to play with technologies that treat 4 patients a year. I want to get involved in areas where there is unmet clinical need. And there's no question that no reflow in STEMI and in ACS is an unmet clinical need that we haven't solved yet. So we're going to talk through one technology that may make a contribution to this and see if we can do better. So I'm going to invite Irene, Professor Lang, who's going to talk to us about what the trials have said and what they haven't said. So, Irene.
Thank you. I'm really enthusiastic about aspiration in any area, but I try to be objective here. My conflicts. We all go by the guidelines. Working in a cath lab, you have to do that. And we know that the routine use of thrombus aspiration is not recommended. And Andrew already told you that the routine is the word here that is really important. Let me show you 2 cases. This is a corona case, actually. I'm showing 2 right coronary arteries. I apologize, I couldn't find any other samples in my repository, but I think it's a good example. So we all see this vessel has attenuated flow. You would say TIMI2, and there is a structure in the proximal part where that is a clot, and that is already in presence of a wire. So if you go one step further, I'm sorry for this. You have to be really, really careful with the mouse. You can see that the thrombus has embolized distally. And this is when I decided to use an aspiration catheter. And it's a very nice demonstration of how the contrast is a biomarker of the aspiration power. And what you get out is very satisfactory for the interventional cardiologist, but also for the end result, which is here. And you wonder where the lesion was. You do afterwards OCT, and you nail down the lesion and decide whether you want to stent. We do know today that it's activated neutrophils who really play a big role there, and they adhere to one part of this vessel. And we have to find that. That's another case, young gentleman with a posterior wall infarction. You see total occlusion, and the total occlusion persists with a wire passed. You see that in the second panel. And then comes the aspiration catheter, and I usually wiggle back and forth to get as much as I can get, and I end up with the culprit lesion. This is what I think today is the culprit lesion. And you would also support this. There's also an aspirate that comes out. Not always are they so nicely shaped. Usually you don't see anything. It's hidden in the aspirate. And from left to right, I show you the lesion, the stent, and the final result. That's very focal at the site of the culprit lesion, and not any further, no 50 millimeter stents, very, very precise. So those should be serving me to give a good example of aspiration, but it leaves us with a dilemma: should we aspirate, should we stent immediately, should we pre-treat or treat with drugs, should we do all of those, or should we do only one of those options? And the meta-analysis of the three trials that I announced in my title, TASTE, TOTAL, and you know, the third one.
TAPAS.
That is TAPAS, of course. That is the meta-analysis that's conducted by Dr. Jolly, and it demonstrates that the cumulative hazard ratio for cardiovascular death is not different between PCI alone and thrombectomy. And of course, this is underlying the guideline recommendation, but we can go a step further. The 19,047, of which 18,300 were enrolled, who taught us that the routine thrombus aspiration did not improve clinical outcomes, and the signal that was seen in the high thrombus burden group with a trend towards reduced cardiovascular death and had a harmful signal of increased stroke, which led to the equipoise of this analysis. It was a patient-based study, so it is really important. However, if you go behind the scenes, the routine aspiration, basically in TAPAS and TOTAL, patients were allocated to their treatment prior to the angiogram. So that should, I think the thrombus should be taken into account, and the mechanism of when the wire passes. Does the thrombus go away? Each device that you use is increasing risk if it's not needed. And also there were differential considerations of stroke assessment. The time of stroke, a TIA, was not collected in TASTE on one hand, and it just collected the composite of stroke and TIA, so the analysis was limited there. The timing is relevant. Before, after wire crossing, I mentioned that. And there was obviously a lack of power, despite the almost 20,000 patients, to tease out the 20% relative risk reduction in cardiovascular mortality. So bigger studies, just to introduce the discussion.
Okay. Okay, thanks, Irene. Come and join us. Right, we've got 5 minutes just to open the discussion. So Juan, I'll go to you first. There's 4 seats over here at the front on the left, by the way. So Juan, some minds are surprisingly closed now. The feeling is that this meta-analysis has answered the question that thrombus aspiration is no longer indicated in STEMI. Do you feel that's the case, and do you feel there's a clinical problem still to solve?
I think that's the great point here, and looking at the audience here, there's a packed room, so I think that all of us here think that there's still an unsolved clinical need. I think that this meta-analysis and all the data that have been collected with conventional manual thrombus aspiration didn't close the debate. I think we do not have found the correct device and the way to manage this kind of patients. So there's clearly some room for improvement, and I think that's these new devices coming currently to the market, like the one we're discussing today, open, I think, the window for a new hope in treating these patients. So there's a clinical need, as you showed. There's convincing data with old technologies, and there's new available technologies that need now to be reinforced by clinical data, by acquiring experience from daily use, and that's, I think, that we're standing now.
Yeah. Can I have a show of hands from the audience? I realize this is a biased group because you've come to this session, but who feels that ballooning thrombus in STEMI is a perfectly acceptable way to reopen the artery, that we need no other solutions? Who thinks we need a new solution other than ballooning thrombus in STEMI? Yeah. So it's a slightly biased group, but that's why you're here, right? You're here. The room is full because we instinctively don't feel it's right to balloon thrombus and send some of it downstream. That feels like the opposite of what we should be doing in STEMI. So I just learned that Jay has used the device we're going to talk about over 1,000 times, which means he's probably used it more than the whole of Europe, because we've only just got the CAT-RX device that we're going to talk about today. So Jay, what made you change your experience, and tell us about the process of that change?
Yeah, so I did the first case in the world in 2017. So that was, it was very telling because, essentially we took a catheter that was designed for use in the brain and then brought it into the heart. And the idea of using powered aspiration over our traditional manual aspiration technologies, which, we were at that point using it fairly selectively, it just didn't, we weren't sure if it was going to work. But, we saw on people, especially with a lot of our STEMI patients, immediate improvements. You take them from the point of extremis to, being relatively routine PCIs at that point. And it was a large paradigm shift. And, even our institution and many other institutions around the U.S. have now largely employed it with high thrombus burden PCI, especially STEMI, to take these patients from a very sick condition to one that's, much more routine.
So this is a continuous suction pump, continuous vacuum. So it's not a syringe that fills up and then has a weakening vacuum as the syringe fills up. It's continuous. And so that is the theoretical advantage.
Yeah, and there's a few things, and we'll talk about it as well too. Not only just the continuous aspiration, which really reduces the the potential for stroke. We'll talk about that, but also the catheter itself is highly trackable, larger than pretty much everything else we've had previously available. So I think it's a combination of these things which really increases the performance.
All right. Well, we better hear some data before we go any further. So Jay, tell us about the Cheetah study, and tell us what it does and doesn't show. So Jay's from Florida in the United States, by the way. I should have said that.
It's a little warmer.
Yeah, well, not this room yesterday. I can guarantee you it wasn't.
So I'm going to talk a little bit about the Cheetah study. And so obviously after Total came out, there was a lot of negativity, especially in the United States, and I'm sure around the world as well too, towards the idea of using aspiration for patients with high thrombus burden. I do have conflicts here too. Obviously, I'm being compensated and do research with Penumbra as well. So with regards to the differences between manual aspiration and powered aspiration, this is a really fundamental difference. When you look at all of the manual aspiration devices, it involves a syringe-based tool to generate your vacuum. Now, as blood fills the syringe, you lose your suction force. So what happened, and I'm sure many of you have seen this clinically as well too, utilizing Export, Thrombbuster, or any of these other technologies, that you may have a clot at the end of your catheter, and then if you lose that suction force, you may lose that catheter down the coronary, or even more concerning, there's potential if your guide isn't fully engaged, you could lose the clot up to the brain and cause a stroke. So the difference between that and a powered aspiration system is that you're able to maintain pure vacuum. We're talking complete vacuum, negative 29 inches of mercury, for the entire duration of the procedure. So as long as the catheter is turned on, you're able to maintain that suction. And the proper technique for this is that you turn on the aspiration the moment you exit the guide catheter. You have a nice guide catheter coaxial to the vessel. You take the catheter all the way down to the area of occlusion. You sit on it for up to 30 to 60 seconds. And then after that, you pull it out and you remain on continuous aspiration until you exit the TUI Bors catheter, at which point you can flush the catheter, you can bleed back, make sure there's no clot in the system. And the reason why it's important to flush the catheter is that sometimes this will actually ingest clot into the catheter, even though you don't see it on the tip of the catheter. So it's important to make sure that's clear before you go back in. And this is really important for those large, high thrombus burden right coronary arteries where maybe you have an ectatic right coronary artery and you have to go in for multiple passes. But in many situations, we were able to see clearance after a single pass alone. So there's 112% more efficiency with regards to powered aspiration in comparison to manual syringe-based aspiration. The second part was the point I made regarding trackability. So this is an export catheter, which was largely used within the total trial. And Sanjeet Jolly, who's the PI of the total trial, he and I talk about this quite a bit as well. And there's a lot of performance issues that happen as well too with export. So the CAT-RX catheter, multiple material transitions, laser cut hypotube, it allows you to go through extreme tortuosity. We've taken this catheter retrograde several times, perhaps down a saphenous vein graft, back up through the circumflex obtuse marginal, but then again back down into another branch. You wouldn't be able to do that with an export catheter. So that type of torquability and trackability is extremely important in order to have effective thrombus aspiration. Now, what Cheetah was designed to do was to hopefully show the safety and performance of the Indigo aspiration system with regards to patients with high thrombus burden who are being referred for PCI. There was 400 patients across 25 U.S. sites. Again, I was the national PI of the study. And this was with frontline treatment, so not ballooning first. We went in with the catheter first before doing anything else. And the idea behind that was we wanted to avoid distal embolization and whatnot too, so we went in with the catheter first. And we looked at the primary endpoint of MACE, which is a composite 30-day cardiovascular death, recurrent MI, cardiogenic shock, or new or worsening heart failure. We looked at the secondary endpoints, which were procedural endpoints, so final TIMI flow grade, thrombus grade, myocardial blush grade, also distal embolization, and also looked at safety endpoints like stroke and major bleeding at 30 days, and looked at the individual components of MACE as well too, out to 180 days. And so these were the outcomes. It was pretty impressive. So within this study population, again, non-randomized, but within this high thrombus burden population, 87% of which were STEMI patients, you can see that freedom from MACE was really impressive at 96.5%. If you look historically speaking, MACE rates are much higher than this. And then also it was extremely safe. So there were no device-related events, no device-related stroke. And immediately post-CAT-RX, able to achieve TIMI 2 to 3 flow in 85% of cases. But at the end of PCI, 97.5% of patients were able to achieve TIMI 3 flow. And then this is pretty impressive here too. So distal embolization was only 0.75%. In fact, it was only one site that had any distal embolization. And if you look at the historical studies, it's up to as high as 15%. And then MBG3 was achieved in 99.8% of patients. And that's like almost an improbable number. When we reported this, a lot of people just didn't believe it. And what was interesting about this, if you look historically, TASTE, and some of the other studies as well, only were able to achieve this in 40% of patients. So this is really tantalizing, and obviously has led the call for us to get some randomized data to really show this. So this was published in Circ Cardiovascular Interventions, and we were able to say that CAT-RX was safe for removal of high thrombus burden with low rates of distal embolization, improved myocardial perfusion. So we know that no-reflow is associated with a lot of consequences, especially increased mortality, higher rates of heart failure, and we also know that large thrombus burden is associated with more MACE and more stent thrombosis. So I'm going to show a quick case here as well too. This is a patient presenting with an STEMI greater than 12 hours earlier. His chest pain free when he showed up. His troponins were extremely elevated, normotensive, pre-treated ticagrelor, and also the usual drugs that we use. This is the initial image. You can see here there's a complete occlusion of the LED. Cross with our wire. This is what we have, very slow flow. There's a lot of calcium there as well too. So initially we try to balloon, and then we get some flow back. So that looks pretty good. Now we go ahead and we're performing IVL. So we performed IVUS, we showed circumferential calcium, and then went ahead and performed IVL proximally. And after IVL, we end up with this. So you can see that we have very slow flow, In many situations, you also end up with no reflow. So in this particular scenario, we went in with the cataracts. I've already crossed here. You can see it's actually coming back up distally. And so you can go through with this catheter all the way down distally and back and forth. Most of the time, it's not necessary to go all the way down distally. However, in this situation, because of a near no reflow phenomenon, I did opt to go down distally, and we do find that sometimes that can even potentially help the microvasculature. Off-label, we've even given drugs through these kind of catheters before, but in this particular scenario, I didn't do that. But people have given adenosine, 2B3A inhibitors. They've even given epinephrine as well too to help with no reflow. So after doing the cataracts, you can see that the flow is improved. And then we went ahead and performed IVUS-guided intervention with Osiro proximally, and you can see that our blush is improved and the patient has TIMI-3 flow. So this patient was chest pain free and discharged later that day post-PCI without any additional consequence. Thank you.
Great. So the key points are bigger internal lumen, more trackable, and continuous suction that may provide better aspiration, but also crucially hold on to the clot as you're extracting in the hope of avoiding stroke. Okay, Irene, what do you think about the technical aspects of this device?
Great. I wonder what was in the aspirate, because I would have never used a shuttering device in a potentially embolic situation like in STEMI. There's clots is hanging around still. I don't want to criticize a big man, but maybe if we do these more advanced procedures, I think it's great to have this kind of demonstration and a powerful solution.
Right. So normally in the past I would have said yes, but because I do have bailout now for these types of scenarios, when we did the IVUS, we didn't see a lot of thrombus, at least with our high definition IVUS. But it's possible that there was some overlying thrombus there as well too. But with the extreme amount of calcium that was there, I didn't want to end up with a suboptimal stent result either, especially in a proximal LED. So I felt in that particular scenario that it's important to make sure that we have stent optimization and then kind of deal with the rest. But in general, I think that if you worry about microembolic phenomenon with calcium as well too, it's interesting. We have, I do a lot of work in the endovascular space, and we've sucked out calcium with this, and we can actually see it. Some even larger versions of these devices where we pulled out large chunks of calcium. So you can pull out, I think, it's not just thrombus, but other types of debris as well.
Do you have a trick how to recover the material from this collection thing?
Well, it's inside of a canister, so you can theoretically send that off to pathology if you wanted to.
You want to look for neutrophils, don't you?
Yeah, well, anything, it's interesting. Fat, maybe.
One, we've evolved a technique locally where, because we have such long travel times where I live, we get high thrombus burdens. And so what we're doing is we're ballooning, and if we get even slow flow, never mind absolute no reflow, we end up doing a sort of halfway procedure. And we cook them with 2B3A overnight, and then we might bring them back 1-2 days later to finish the PCI. Is that something that you do? Is that something that the audience should be considering at the moment, or should we be looking at different ways of handling this problem?
It's a great question. In the meta-analysis, the 2B3A patients did better.
Yeah. And direct stenting.
Which may be a hint, that we might practice. Usually 2B3A is only used in very bailout situations in my lab. So I haven't used it for some time now. But maybe a good reminder.
Yeah, what?
Well, from our experience too, when you have these very late presenting patients with organized thrombus, it's quite a challenge to remove it using manual thrombus aspiration device or conventional devices. And I have to say that we did some cases with these late presenters and quite organized thrombus. And actually this device performs very well, probably better than conventional devices. So in my perspective, at least from our experience, we do not stage the procedure, but we managed to get most of the thrombus out during the index procedure using this technology. Yeah. As mentioned, we can also deliver medication directly into the aspiration catheter. So we deliver intracoronary GP2B3 inhibitors as well. But I have to say that's really impressive how you get out the thrombus during first or second pass, even if it's organized. And I will show a case later.
There's a question coming through the computer saying, should we be giving GPI drugs up front? So Jay, what has happened to your 2B3A inhibitor use before 2017 versus now? Is it gone up, gone down, stayed the same?
I mean, some of the staff members don't even remember how to use it. So it's we used to use a lot of 2B3 inhibitors back in the day. You know, we used to have ReoPro, which is no longer available. So it's mostly tirofiban and obviously using eptifibatide. But the utilization of 2B3A now is very, very selective. Obviously, it's still associated with some increased bleeding risk, especially we have a mostly elderly population in Florida. So a lot of these patients have more bleeding phenomenon when we put them on infusions of 2B3A. So we try to avoid it as much as possible. This device and a lot of the things that we've been doing with modern PCI have really limited the need for it.
Right, I have a mobile microphone here. So if anybody has a question, we have the most experienced operator in the world with this device and also the lead for the study. So, here we go. Right, we have a question here. Just tell us where you're from and then ask your question.
I'm from India, and I have experience of using this catheter. I'm presenting it tomorrow as well. How has the amount of pre-dilatation reduced in your practice?
Great question.
And I think so we can address that because the DISCO 3 trial back in 2003 said that 50% of the patients don't require pre-dilatation. Mm-hmm. So if we could have our experience about the all-comer setting, how the pre-dilatation reduces, maybe that.
There are some signals in some studies, aren't there, that if you can direct stent in STEMI, you may get a better result.
So with this Cheetah, with this CAT-RX, maybe if we could say, means my personal experience is my pre-dilatation balloon has reduced by 60 to 70%. It was 50% that time. And even in calcific lesions, just like your case, it was, I also had a similar experience of ostial LAD, very calcified lesion. I could not cross the catheter, but I had a distal TIMI 2 flow with this aspiration, and that was huge. And I, in fact, after that, taking in the pre-dilatation balloon was to optimize my result. I did not use IVL, but I did a pre-dilatation and there was no slow flow. So
it's a very a good point. And so essentially in that particular case as well too, normally I would have just gone up front with the device, but since we already had difficulty we knew, because of that extreme calcium that was there, that's the reason why we ended up having to balloon. So sometimes you do have to balloon up front, but you're right. Within our experience now, our upfront ballooning has dropped extremely low levels. So we're going, if you have a high thrombus burden, grade 4 or 5 thrombus, we always go upfront now with aspiration first. And then what the protocol, this is something that we're going to have to study. The algorithm that's been developed around, at least in the US, has been to aspirate, IVUS, then stent. And so then you do, instead of direct stenting per se, it's IVUS guided direct stenting. And really that seems to work very well. And then if you have to do additional optimization afterwards, you certainly can.
So when there's another question online, a very interesting one. Is there any role for adjunctive thrombolysis? We've talked about 2B3A. We can maybe reduce that by more effective aspiration. What about lysis? Are you ever using that? When?
We don't, to be honest.
No. Irene, you feel like you might.
Thrombolysis activates platelets, so we don't like it.
No.
In the coronaries.
Yeah. There's some stuff on Twitter, isn't there, of occluding both ends and then dissolving the thrombus with
lipid. It's a JAG marination technique. So you put a blocking balloon down and they instill 2 to 3 milligrams of TPA. Yeah. The only scenario where that really may be considered, I personally don't do it very often. I've done it maybe 2 times. But it's a mega right coronary, 6 to 8 millimeters in size, massive thrombus burden, very organized. And CAT-RX, the reality is it struggles with those kind of scenarios. We've even used larger catheters like the CAT-6 with an 8 French guide, which is very off-label. But sometimes the thrombus burden is overwhelming. But I've even done those with multiple passes. My record, I think, was 24 passes. And it was able to open it on the table. But that's a lot of work. So instead of doing that, some people have opted to do a combination technique where they'll still a little bit of TPA, wait, 4 or 5 minutes, and then go ahead and try to aspirate it out. But it's, I think it should be done very rarely.
Yeah, we've got a lot of questions now. Irene, if I can only afford to use it in 10% of my STEMI cases, which one should I be selecting and why?
Which one what?
If I can only afford to use the CAT-RX in 10% of STEMI cases,
okay.
which one should I select and why?
Please select STEMIs.
Yeah.
Please select high thrombus load, which is easy to find if there's persisting no-flow, slow flow after passing the wire.
Yeah.
Please, I couldn't even say aspirate proximally, but that would be my first choice.
Yeah.
But maybe not, It's the total thrombus load that should drive you.
Yeah. And any preference for a vessel? Because we've seen that the bad outcomes with no reflow in the LAD. At the moment, you're getting consecutive experience. Are you going to become selective? And if so, any advice on how to select?
Well, I mean, the criteria for me is the thrombus burden, and it's most likely found in LADs and right coronary arteries, to be honest. That's where we select to use the device. And there's maybe one technical point I will just to mention here following Jay's presentation, which is really nice. There are some other available technologies on the market, like stent retrievers, for example, that are currently used and studied in Europe. Unfortunately, these devices cannot be used in heavily calcified lesions and for stent thrombosis, for example. It's contraindicated. So this technology as well, may overcome the limitations of other technologies currently available because they can be used in these scenarios. And the stent thrombosis, for example, is a great indication for.
Well, I think we should see your cases, and then we go 5 more minutes. If anyone else in the room, if you just...
Amongst the technical aspects that you were just discussing, maybe like in that case, one more difference from the conventional aspiration catheter is its forward-looking suctioning force.
Yeah.
In all other catheters, it was a slant and it was sucking from the side. In this, it is sucking right from ahead.
Yes.
And one of my cases, I had a beautiful experience in doing a CTO ISR.
Yeah.
It was a CTO, and it was a CTO, 3 months old, and it aspirated the thrombus from even a CTO. It's not just a subacute thrombus, maybe even a long thrombus.
Fantastic.
Thank you.
We'll just take a very short question at the back there. Put your hand up again so people can see you. If you keep it very short, please, just so we can stay to time, and then we'll come back to it afterwards.
I just wanted to ask, is the efficacy the same depending on the time of presentation? So
that's a very good question.
Late presenting thrombus, which we see a lot
so
in Africa.
within the Cheetah study, we did it just like total, so less than 12 hours. There's clearly a difference within patients that have more organized clot, and in those situations, it is still effective, but you may have to do some additional ballooning as well.
Okay, great. Let's move on. So, Juan, show some cases.
Well, so we started our experience with the device a few months ago when actually the device became available in Europe, and I will share with you here some cases that we did and mainly the indications that we feel this device can be useful for. So here 2 slides as an introduction just to set up the framework of what we are doing currently. So as we already discussed, the management of high thrombus burden remains a challenge and an unmet clinical need in patients with STEMI undergoing primary PCI. And despite the fact that routine manual thrombus aspiration does not improve clinical outcomes in all comer patients with STEMI undergoing primary PCI, there is still remaining uncertainty whether this could be of potential benefit in patients with high thrombus burden for whom this is a clear biological rationale for the greater benefit. Unfortunately, as we can see here in a sub-study, a pre-specified sub-study of the total trial, including more than 10,000 patients, more than clearly 9,000 patients with high thrombus burden, the presence of high thrombus burden during primary PCI increases by a nearly 2-fold the risk of cardiovascular death. Unfortunately, and this has been already highlighted by Irene in an individual patient data meta-analysis, including 3 trials, more than 18,000 patients, when we look at cardiovascular death among patients undergoing manual thrombus aspiration with conventional devices versus PCI alone, there's no significant interaction according to the presence or absence of a large thrombus burden as defined by a TAPAS thrombus grade of 3 or more than 4. But when we dive a little bit more in this data, we see that the clinical outcomes are 30 days. In the subgroup of patients with large thrombus burden, there's a signal suggesting a clinical benefit of manual thrombus aspiration at the expenses, though, of an increased risk of stroke. And this is, for me, the background that highlighted the need for, using newer technologies and newer devices in order to further improve the outcomes of our patients without causing or trying to cause additional harm. So let me here show you a case of a 70-year-old male with type 2 diabetes, dyslipidemia, ex-smoker, who presented to our institution with 3-hour typical chest pain at rest. The ECG showed anterior ST elevation myocardial infarction, and the patient was preloaded with aspirin and unfractionated heparin. Our patients are not preloaded now with P2Y12 inhibitors when they come to the cath lab, and he was transferred to our primary PCI for an coronary angiogram. And as you can see here, we found highly thrombotic occlusion of the proximal LAD with no significant disease on the circumflex and the right coronary artery. So due to the high thrombus burden that we see here on the coronary angiogram, with a high likelihood of distal embolization, and considering the current limitations of the available manual thrombus aspiration technologies in terms of the risk of stroke with these proximal lesions, we choose to work with the CAT-RX device that I will show here a very short video to show you how easy it is to set up the system. So you have here the sterile package with the device and the aspiration tube. First, you have to secure the non-sterile canister with one click on the aspiration pump. And then you pass from a sterile file filled to your cath lab team the tube, which is then connected, and you just ensure that the position of the aspiration tube is in a position off, as you can see here. Then you connect it directly to your aspiration catheter, and you power on the penumbra engine, and you wait for approximately 20 seconds to have the 4 LEDs illuminated that indicate that the vacuum is created. The overall process takes, something like 30 seconds. So it's very, very easy to use and to set up on the table, even in emergent cases. So this is here how we handle very gently the device. It was not a very challenging anatomy, as mentioned by Jay previously, but this is very important to do it in a way that you're not pushing the thrombus down the artery. So with very gentle passage, we here get into the vessel, aspirate the proximal segment of the LAD, and this is the angiographic result after just one pass, restoring completely antegrade flow with a TIMI3 flow down the LAD. As it was among our first cases, we decided to go for a second pass. So this is here the second pass, going very gently across the lesion here, trying not to embolize the residual thrombus. And what we realized actually that most of the thrombus was already removed during the first pass. So it's really impressive to see that with continuous aspiration, in these very easy cases, you may read of the thrombus like here with only one passage and a few seconds of thrombus aspiration. We then went up for a hybrid primary PCI approach of the LAD with a proximal biodegradable polymer sirolimus eluting stent implanted at 12 atmospheres, followed by a sirolimus-coated balloon on the mid-LAD, and further post-dilatation with high-pressure balloon to the stent, and we get this final result with a TIMI free flow, and as you can see, a myocardial blood grade of 3. So the hospital course of the patient was uneventful, despite a peak CK rise of 2,460 units per meter. The LV function was only mildly impaired, acknowledging that it was a proximal LAD, and he only had at the ends on mid to apical anterior and mid-anterior septal hypokinesia. The patient was discharged at day 6, and we have a 30 days follow-up. The patient is symptom-free and did not present any clinical event. Here is a second case of an 83-year-old male with dyslipidemia and hypertension, a late presenter or a slightly later presenter than the first case. The patient came to our institution with an 8-hour typical chest pain at rest. The ECG showed a 3rd-degree AV block and inferior and posterior ST elevation myocardial infarction. He was preloaded with aspirin and heparin and transferred to a center for coronary angiogram. Here you can see the left system with some disease on the proximal LAD as well on the circumflex, and a quite large thrombus sitting on the mid-segment of the right coronary artery. As you can see, we start the procedure by inserting a temporary pacemaker due to 3rd-degree AV block. So this is typically the kind of thrombuses that we were really disappointed when trying to use manual thrombus aspiration with conventional devices. So we went on again with the CAT-RX system, and you can see here the first pass that we did across the lesion by getting towards the lesion and then aspirating back to the guiding catheter. And this is the result that we have after just one pass. So it's really impressive how this kind of thrombus that we used to be really disappointed of are easily removed with the device. The lesion was then stented with two drug-eluting stents to the mid and the proximal segments of the right coronary artery, and this is the final angiographic result with a TIMI-3 flow and a myocardial blush grade of 3. Again, the hospital course was uneventful. The echocardiogram showed only mildly impaired LV function with inferior infrareceptal hypokinesia. We completed the workup with a cardiac PET CT showing no residual myocardial ischemia and only a minor scar in the right coronary territory. The patient was discharged at day 5 with no clinical event and no symptoms documented at 30 days follow-up. So in conclusion, a high thrombus burden during primary PCI for STEMI is associated with an increased risk for cardiovascular death, and we have to remember that. And the optimal management of high thrombus burden during primary PCI in STEMI remains a challenge and a clear unmet clinical need. And this comes back to Andrew's first slide. There's a need for additional devices in treating these patients to improve outcomes. Available evidence suggests that the potential clinical benefits of manual thrombectomy compared to PCI alone in high thrombus burden patients are in the expenses, though, of an increased risk for stroke and TIA. And this discloses the need of novel thrombus aspiration technologies to further improve the clinical outcomes of our patients. And there's no doubt that the CAT-RX continuous mechanical thrombectomy aspiration system may potentially overcome the current limitations of manual thrombectomy and represents a game-changing technology for high thrombus burden management during primary PCI among patients with STEMI. And with that, I'll thank you for your attention.
Okay, that's great. So I've used it in complete heart block, and I actually think that might be the most golden group, because if you balloon and embolize even a small amount into the AV nodal branch, you may have persistent heart block. And so the case I used it on, it just immediately reverted to sinus rhythm.
Yeah, exactly.
And so,
the same in my case, actually. The temporary pacemaker was removed at the end of the procedure. Yeah, it restored complete sinus rhythm after thrombus aspiration.
So I think if you've got two on the shelf, then take one of them off for that. Okay, right. We don't have randomized data, right? So this isn't technology backed up with level 1 evidence. Do we need, a gigantic trial of 9,000 patients? Can we do it in a different way? Can we be more smart with how we acquire evidence? The days of these 10,000 patient interventional trials, they're very difficult to do these days.
Yeah, that's what we were trying to do with the subsequent trial at Cheetah ACS, but unfortunately we got a little pushback and they did want 8,000 to 9,000 patients. But I do think that we have a number of other surrogate markers that we can look at. We can look at infarct size reduction. We can look at other surrogate endpoints potentially as well. The hard endpoints of cardiovascular death, NMI, whatnot too, sometimes can be a little more challenging and do require the very large studies to be able to get those kind of outcomes. But what's interesting though is that if you look at the MACE rates in the original Cheetah study, they were extremely low. So maybe we don't really need that many patients. And I would argue that 4,000 or 5,000 patients could get us our answer.
It's so difficult to estimate sample size. There's a question here.
Yeah, thank you very much. This is a beautiful presentation and a very interesting topic. I think we all use thrombus aspiration despite guidelines because we feel that it will ease the procedure. Maybe the impact is not in survival X years ahead, but it's something that you will choose a shorter stent. The procedure will be completely different. And I have a question to you. What would be your recommended protocol for anticoagulants and antiaggregants before thrombus aspiration?
Do you want to take that? You've used
Sure. Our protocol is still the same as any other STEMI or NSTEMI patient that comes in. So we tend to use upfront. We preload typically with our antiplatelet of choice, and usually thiionopyridine. And then usually we use a fair amount of heparin primarily. So we don't typically use TB3As up front. There's some cangrelor usage as well too, because we do have a fair number of patients that end up requiring bypass as well, and we're not sure exactly what we need. But other than that, there's nothing special that we use with these particular patients.
Okay, we're into our last minute, so very short question, if you wouldn't mind. Sir.
Yes, for a practical aspect, which is your strategy? You go with the catheter in front of the thrombus and wait, maybe that the catheter stop to aspirate, or directly you pass through the thrombus if it doesn't stop, because the risk of embolization with the high thrombus burden. Thank you.
I think sitting on it, we used to go through it all the time, but we found that didn't make a difference. So just go right up to it and sit on it and then wait and then come out. And then you can always go in for another pass. If there is something hard there, you can imagine a scenario that even if you're aspirating it, you could be pushing it downstream. So there's no real advantage to doing that. I don't know if anyone else agrees.
Agree.
Yeah,
Yep.
agree.
Well, unfortunately, we've run out of time. So what I'll summarize with is it's a promising device. We don't have randomized data. But what's fascinating is we have randomized data that the devices we have on our shelf are potentially harmful and we still use them. It's a very odd situation. We've proven that these thin devices with manual aspiration could be harmful, and yet we still use them. So we've now got something that may offer a different approach. I think we're still learning about it in Europe, and we're grateful for Jay for his experience. And we're going to wrap up the session there. Thank you for coming. And you can learn more about it if you head towards the penumbra people. All right, thank you.